fortunate to have Dr. Michael Sabel, who was originally from the Philadelphia area, spent some time in Temple, was at Roswell Park, and has been on faculty here at the University of Michigan for some time now. A fantastic college in surgical oncology, so we'll talk about melanoma surgeries and the new era of systemic therapy.
Thank you very much. Thank you very much for having me. It's very exciting to be here to be able to talk to you about this. I'm going to go in a little bit of a different direction. I'm going to get a little bit basic here in terms of talking about what we do for surgery. I tried to sort of gear this to address a lot of the questions that people have for surgeons about what it is that we do, why it is that we do what we do. And I wish I could tell you that we had the answers, but by the end of the talk you're going to see that in today's shifting landscape of multidisciplinary care, this has actually been changing quite a bit. And as we see these advances in the systemic treatment of melanoma, it's going along with changes in what we may want to do as surgeons and that coordination of care. So this is going to vacillate quite a bit as we talk, but there are several things that once you are diagnosed with melanoma, you typically would come see one of my colleagues in surgery, and there are several goals that we have in terms of treating melanoma surgically. Obviously, that primary issue is dealing with the primary tumor, the one that's been biopsied. How do we manage that to try to lower the chance of it recurring in that area to the lowest possible ability? The more controversial area today is what do we do about the lymph nodes, particularly because most patients, 95% who present with melanoma, have no clinical evidence that the cancer has gone to their lymph nodes. About 5%, maybe 5 to 10% of patients, if you do a good physical examination on them, you can feel an enlarged lymph node in the area that drains that melanoma. And of course, those patients, when we talk about surgery, we're talking about removing both that group of lymph nodes as well as the primary tumor. But the great majority of patients, they have no clinical evidence, and yet we know a number of them have microscopic cells. And is there a benefit to finding that out early? And while this has been controversial, again, this is one of those things that's changing in that shifting landscape. And of course, then there's the even more controversial area of what happens when the cancer comes back. Is there a role for the surgeon in the treatment of that disease? So if it comes back in the lung, it comes back in the liver, should that patient consider surgery as a treatment option? So let's start with the resection of the primary tumor and what it takes in order to get control. And melanoma is an unfortunate and unusual disease in that whereas most cancers, negative is negative, if we can get a good margin of normal cells, 1 millimeter, 2 millimeters around the tumor, that's typically adequate in preventing it from coming back. But melanoma is different. It has an unusual biology in that it tends to spread, it tends to spread within the dermis and within the lymphatics underneath it to a degree greater than other tumors in the surrounding tissue. So we actually need wider margins around melanoma in order to prevent it from coming back. And this is often an area that patients ask quite a bit about because many patients who have melanoma have had skin cancers before, like basal cell carcinomas and squamous cell carcinomas that have been resected with a small margin. And here I come saying that we're going to need to take an inch around this, and it causes quite a bit of confusion. But this is what we basically recommend for the resection of the primary tumor, and we base it on depth. How deep is the melanoma growing into the skin? The Breslow thickness is our greatest prognostic factor. It tells us the most about what's going to happen with that melanoma in the future. So we recommend about a centimeter margin when you're diagnosed with a thin melanoma. A thin melanoma is defined as less than 1 millimeter. And I want to emphasize one of the points that was just spoken about is the benefits of screening, the benefits of early detection of melanoma. And we always measure this in terms of mortality, and that's obviously a very important endpoint. And that's where some of the controversy is. Well, does screening and finding these things earlier really impact outcome? But what is very rarely taken into account by groups like the USPTF and others is the impact of finding disease earlier, even if it doesn't change mortality, the impact on treatment and what we need to do in order to successfully cure that melanoma. And so here you can see that early detection, we talked about how self-detection and skin examinations and clinical examinations can find a greater percentage of patients who have that melanoma less than 1 millimeter. Well, that translates to a rather significant decrease in the size of the skin that I need to take around it. And obviously that translates to less skin grafts, smaller scars, less tightness and restriction of the extremity, and significantly less morbidity. And so there are other measures that, from our point of view, are very important in terms of the early detection. We have a gray zone here. If you have a melanoma between 1 and 2 millimeters, we usually recommend somewhere between 1 and 2. Well, why is there that gray area? Well, what a lot of people don't know is before several randomized studies that led to these current recommendations, we used to recommend taking 5 centimeter margins around melanoma. So this is going back quite a while. But these were rather large excisions that almost always required skin grafts or open areas that took a very, very long time to heal. And 5 centimeters was even a conservative estimate. There were several melanoma experts going back 30, 40, 50 years who were recommending 10 centimeter margins or go as wide as feasible in order to get control of the disease. And this led to multiple randomized studies where patients were randomly assigned to either have thin margins, 1 centimeter, 2 centimeters, or the 3 to 5 centimeter margins that we've done in the days. And again, I emphasize this is the importance of that participation in clinical trials, because without patients agreeing to be randomly divided into these groups, we would never be able to answer a lot of these questions. And so we would still be doing 5 centimeter margins if it wasn't for the patients who were so kind to participate in these studies and really let fate decide for them what we were going to do. And then, of course, from these randomized studies, we do recommend that if you have a thicker melanoma, this is going to require a 2 centimeter margin. But we very rarely go past 2 centimeter margins. There really isn't any benefit to that. And so those 3 centimeter, 4 centimeter margins are a thing of the past. So what do we do in the operating room? Well, we have this melanoma and we want to make sure we take our adequate margins. So if this is a thick melanoma, then we want to measure our 2 centimeter margins in every direction around it. Patients always ask, well, do you have to go 2 centimeters deep? We basically go down to the underlying muscle or fascia. We don't really measure how deep we go. But circumferentially around the melanoma, we want to measure and make sure we get adequate margins around the border of that melanoma. And then, of course, that leaves us with a circle. If I take out a circle of skin, I have to either do a skin graft, or if I want to close it, I have to take out more skin, because I can't close a circle. If I do, the ends are going to pop up, and we're going to have what are called dog ears, rather dramatic dog ears. And so what we really want to do is get an ellipse that's a 3.5 to 1 ratio of width to length. All right? That really minimizes the dog ears. And as many of you unfortunately may be aware, if we don't get all the way to 3.5 centimeters, you may have those little bit of poofs at the end of the incision where it stands up, and those are what we call dog ears. But this is unfortunately why the typical melanoma resection results in such a large scar. It avoids the skin graft and this eventually heals, but it does leave a rather lengthy scar, which is again one of those questions that we often get. Now, this is a melanoma on an extremity. We can usually get our margins adequately here, but as you can imagine, there are many situations where we can't readily take that, elevate the skin on both sides, and fill in that defect. So often we need to do a skin graft. And here are some examples on the lower shin, on the foot, where we have to unfortunately do a skin graft in order to get that to close. And there are other areas where we can really only do as best we can. We obviously can't get 2 centimeter margins in areas that are close to the eye or the ear, the lip, and in these situations we try to minimize the cosmetic impact while still getting an adequate margin around the melanoma. But we do know that this is often associated with an increased risk of the cancer coming back. And this is where we're hoping that maybe the impact of systemic therapies could hopefully not only reduce the chance of the cancer coming back elsewhere, but also reduce the chance of the cancer coming back in the area where the patient has had surgery. Now, the wide excision has been stable for many, many years. There's not a lot of controversy there. This has sort of been the standard of care going back several decades in terms of getting these adequate margins around it. What has been slightly more controversial lately, not in all of our eyes, but in some people's eyes, has been what do we do about the lymph nodes, and specifically the patient who we call clinically node negative, meaning you've come in to see me, we have a melanoma, we need to deal with it, we do a good examination of the regional basin, that's why we push underneath the arm so aggressively, trying to feel if there's any large lymph nodes that are maybe a sign that the melanoma has already spread to the lymph nodes. But we know the majority of patients were not going to feel that. But there could be cancer cells in the lymph nodes that we just don't see. And this is where we have recently introduced the use of sentinel lymph node biopsy. This is a diagnostic test. It's a method of identifying those patients who have microscopic disease within their lymph nodes that we would never know. It's not going to show up in a blood test, not going to show up on an x-ray, and we're not going to feel it on physical examination at the time that you come in with the diagnosis of the melanoma, but those cells are there, and left to their own, they're going to get larger. We're eventually going to be able to feel them. And what we worry about is that in that time period, they could spread from the lymph nodes to the rest of the body. Many of you are probably familiar with how this procedure works. It's rather simple. We inject tracers around the site of these melanomas. These tracers are designed to get within the lymphatic vessels and spread to the lymph nodes that drain the area. So, They're not going to the lymph nodes because there's cancer in the lymph nodes, and this is something I emphasize with every patient, and then emphasize again in the pre-op area when they see their x-ray. The x-ray doesn't light up because there's melanoma in the lymph nodes. It lights up because that's the way you're put together, and we want it to light up. We want to be able to find that lymph node so that we can look at it under the microscope. We use a combination of a radioactive tracer and a blue dye. Both do the same thing. They travel to the nodes. We take out those lymph nodes as a surgical procedure so that we can look at them under the microscope. It is not a perfect procedure. If the report comes back negative, that is an excellent sign, but there are going to be those patients where the tracer did not go to the right basin, did not go to the right node, or the pathologist failed to see what can be very, very tiny cells, because we obviously can't take the node and completely dissect it. We do the best we can. We thin section, we look very carefully to try to identify that disease, but it is a very, very good way of detecting whether or not there's cancer in the lymph nodes. Now, at first blush, it may make no sense. Why wouldn't you do this? Why wouldn't you take every patient and do this procedure in order to find out whether or not there's cancer in the lymph nodes? And some people feel we should be doing it on every patient. Other people feel that it shouldn't be done at all. And it's one of the controversies that we deal with. And for those of you that have been treated here, and I see a lot of familiar faces, as Dr. Lau, obviously we don't find it as controversial. Most major centers don't. But there are some legitimate pros and cons to whether or not every patient should have this procedure. Yes, we identify microscopic disease in the lymph nodes early. Does this directly benefit the patient? Well, the data is not quite as clear as we would like it to be. We do know that it'll stop it from coming back. So if that disease is in the lymph nodes, it is likely to come back. It could be a year, it could be 2 years, it could be 5 years from now. But this way, we get it, and we get it out now, and there's actually less morbidity to the patient, meaning when we have to go back in and get that cancer out, there's less side effects to doing it early than waiting until it comes back. And we had a very nice study here at the University of Michigan that showed that extremely well. And again, it's one of those benefits to early detection in terms of side effects, whether or not it really impacts mortality, but it's still a significant benefit to the patient. And taking out a sentinel node is of relatively minimal morbidity. There are very few side effects. You can get some side effects. Every surgical procedure obviously has its complications, but it's relatively minimal. But there are cons to the procedure. Many patients with melanoma, we would be able to do that wide excision under just some sedation or even just local anesthetic alone in the office. Whereas doing the sentinel node biopsy means we have to go to the operating room, and we tend to use general anesthetic for that. So obviously we're now looking at the risks of general anesthesia. And as we start to get into populations who are a little bit older, maybe have some heart disease, and going to the operating room isn't quite as safe, we're running into that sort of risk-benefit balance of who should be going to the operating room or not. And it is more costly. Going to the operating room and having a procedure under general anesthesia does increase the cost of care. And obviously, we don't look at that on the individual basis, but somebody does have to be responsible for this. And so when you look at the large numbers, we have to think about how much more we're spending and are we putting the money in the right place. And so this is why sentinel node has been a little bit controversial, but it's also where we're seeing some changes in terms of, like I said, that shifting landscape. So most of the argument comes from this study. This is the MSLT-1 study that basically tried to answer the question of should patients have a sentinel lymph node biopsy or not. It randomized, again, patients did not have a choice. If they agreed to be part of the study, you were randomly assigned to either have the melanoma taken out with a wide excision alone, or we combined that with a sentinel node. If the sentinel node was positive, you returned to the operating room where we did a complete node dissection. We'll talk about that in a little bit. If you were negative, we kept a close eye on you. And what did we learn from this study? Well, we clearly showed, and there was no surprise here because we knew this from many studies before, that if your sentinel node does have cancer, the chance of this melanoma coming back is much higher. It is prognostic. It predicts the patients that are more likely to have that melanoma come back. Now, when this paper came out, this was dismissed. And the argument for dismissing it was, well, what do we do about that? Because we really don't have anything to offer those patients. Because this is in an era where we really didn't have very effective systemic therapies. But now, we're in this new era. And I'm foreshadowing a little bit what Dr. Lau is going to talk about when he comes up here, but we're in a very exciting time in melanoma, where all of the research is now starting to lead these new agents that are effective in controlling melanoma, or maybe have promise at being effective in melanoma. And so this is changing our opinion in terms of sentinel node biopsy. So again, to know that the patient has a higher chance of the cancer coming back, but to not be able to do anything about that, all that really translates to is being able to give bad news. And so you have to question whether that's really worth putting somebody through an extra operation, putting them through the general anesthetic. but it clearly does identify those patients who are at a higher risk. If you do subset analysis, meaning if you just take a look at the patients who were node positive, either because we found it on their sentinel node, or because they recurred when we did not do a sentinel node biopsy, it turns out that there's probably about a 15% improvement in survival in detecting that disease early. Meaning, if your cancer is detected not because we found it early by doing the sentinel node biopsy, but rather because it came back later, when we didn't do the sentinel node biopsy, and then you come back in a year or two later and you have that palpable lymph node, the likelihood of the cancer not coming back someplace else is going to be much greater. This even includes those patients who had what's called a false negative, meaning the sentinel node biopsy did not show cancer, but the patient recurred in the nodes, meaning for one reason or another, the ones we talked about, the sentinel node biopsy was just inaccurate. And so there is this benefit, the survival benefit, for the patients who are node positive. But of course, in this study, only 16% of the patients had disease in their lymph nodes, which means we were only seeing a 10% improvement in survival among 16% of patients. So that really translates to a very, very small overall benefit. And that's why you have to think about whether or not you want to take somebody to the operating room for this added procedure when the risks of taking them to the OR, such as the general anesthetic, is high, or the likelihood of finding disease for those patients with a thin melanoma is low. Because that's where that risk-benefit ratio may start to tilt away from the patient. All right? And so that's why we have these discussions with patients about the pros and cons in any situation about doing a sentinel lymph node biopsy. It isn't sort of an easy decision in all of these settings. But one of the criticisms of this study is that we're comparing maybe apples and oranges. How do you know that every patient with a positive sentinel node would have gone on to recur? Maybe in some of those patients, younger patients, healthy immune systems, that disease would have been eradicated on its own. That doesn't seem to be a legitimate argument, because if you look at the long-term follow-up of these patients, almost the numbers match up. And the data seems to suggest if you had disease that we found in your sentinel node biopsy and we didn't remove it at the time, it was destined to come back. And so that argument has sort of fallen off to the wayside a little bit. We are definitely helping those patients by finding the disease early. It's just a question of the numbers. But I want to go back to this slide that we just showed again, in the prognostic significance. Is there a benefit to identifying the patients who have disease in their lymph nodes? And again, this is where that shifting landscape comes in. So if we go back to sort of 2007, and what options Dr. Lau and his medical oncology colleagues had to offer patients who either had metastatic disease, as you can see the stage 4 on one side of the slide, or in the adjuvant setting, meaning these are my patients who are high risk of the cancer coming back, but I've taken out everything that we know is there. That means, can we lower the risk of the cancer coming back in those patients? And we have very few options. In the adjuvant setting, really only high-dose interferon, and as you're about to hear, there are some controversies as to how effective it is, and is it worth the toxicity or the side effects? And so we had very little that we could offer a patient if we even did identify that they were at a higher risk of the cancer coming back. But as we move forward, we have increasing options, both in the stage 4 setting and in the adjuvant setting. So in 2011, we had the introduction of a new way of delivering interferon with a little bit less toxicity, although for a longer period of time. And again, there's some pros and cons to that. As we keep moving forward, and I was very fortunate to be head of the Melanoma Scientific Committee at ASCO during this time period, so I got to actually be involved with the presentation of a lot of these during a very exciting time in melanoma, very media friendly, and all of you are probably very familiar with all of the articles that are now coming out during this time period. New drugs in melanoma, an improvement in survival in stage 4. So it's very, very exciting. But it's also expanding our repertoire of drugs. But what we're particularly excited about is, as you can see, we have all these new agents that Dr. Lau is going to get into a little bit more detail about in the metastatic setting. And what we're really looking forward to is moving that over into the adjuvant setting. Which of these drugs are not only going to help the patient who already has stage 4 disease, but help lower the number of patients with high-risk disease from developing that metastatic, that stage 4 disease. And so, the importance of the sentinel node biopsy in identifying those high-risk patients has now taken on a much greater importance. And identifying patients for these clinical trials, as well as for consideration of therapy with these new drugs as they come down the pipe, is increasingly important. And so the benefit of the sentinel node biopsy, I think, is becoming more and more important, and the controversy is going to the side a little bit. Now, as you are familiar, and as was in that original design, if your sentinel node is positive, we have typically recommended going back to the operating room for a complete node dissection, where we remove all of the lymph nodes from the area. And that's because, as we know, In many patients, the sentinel node is the only node where the disease has spread to. And in fact, our studies show that 80% of patients, when they go back to the operating room, they do not have additional disease in those other lymph nodes. But 20% of patients, the cancer has spread to lymph nodes that we haven't yet removed. We only take out the lymph node that has the tracer, the first one to receive the drainage. And it can be more than one node that takes up the tracer, but there can still be other lymph nodes in that chain where the cancer has spread to that we haven't removed. And the only way to go back and get those nodes is to take out all the nodes in the area. A very common question I always get is, well, why not give the tracer again? And then see what the next node is, and the next node. It doesn't work because we've already disrupted the lymphatics, so the flow is not the same. The other question I often get from patients is, well, you took out 3 nodes, and 1 was positive, but the other 2 were negative. So doesn't that mean the next 2 were the ones down the chain? That doesn't actually work either. And we've looked at that in several different predictive models to try to figure out who needs to go back and who doesn't go back. That actually doesn't work because these nodes can often be draining in parallel rather than serial nature. So right now we have very few good ways to say who should go back to the operating room and who doesn't need to because they don't have disease in those other lymph nodes. Because again, this is not disease that shows up on x-rays or there's any other valid way to sort of separate those 2 groups. And so typically we do recommend going back to the operating room for a complete node dissection. So for example, if you had a map to the axilla and your sentinel node positive underneath the arm, then we go back and do what's called an axillary lymph node dissection. We take out all of the lymph nodes that are here underneath the arm. Now, this is not really what it looks like to us. There's actually sort of a fat pad underneath the arm, and we don't see the individual lymph nodes. We don't pick them out, sort of cherry pick them out. What we do is we go in and we clear out that entire fat pad where the lymph nodes are. We send this to the pathologist. They'll look through the lymph nodes, let us know how many were in the specimen and how many had melanoma in them. Well, why not do this? Why not just go back? If there's 20% risk that there's disease, why even hesitate? And of course, many of you know that the reason is because this is a larger operation with more side effects. There are short-term side effects, infection, bleeding, injuries to the nerves. Those are low risk, but it is really lymphedema that has us the most concern. Going back and taking out the remainder of the lymph nodes can increase the likelihood of swelling of that extremity. And this can be a lifelong problem. It is manageable, but it requires exercise, physical therapy, massage techniques, and most commonly, the use of a compression stocking either on the arm or the leg in order to minimize the impact of this. And so if this operation is not really helping everybody, and yet it's exposing everybody to these sort of complications, we'd certainly like to minimize that. And this is another area that's a little controversial, and these are some numbers and these are some concepts that I have to have with patients on an individual basis about the pros and cons of going back to do that complete dissection. Let's say we take 100 patients with a positive sentinel node. So 100 patients have gone to the operating room, I've done a sentinel node biopsy, I found cancer in that lymph node, all right, and this blue bar represents those 100 patients. Well, as we know, many of them, the sentinel node was the only node that had disease. So going back and taking out a bunch of negative nodes exposed the patient to risk, but didn't really help that patient at all, okay? And if I had any way of identifying them, I would, but we don't. How many is this? Well, the study suggests it's 80%, but that's probably not true, because in many of those, we don't look at those other lymph nodes as carefully. So there could be that tiny disease, those cells, that the pathologist never saw. We get a report back saying 0 of 20 nodes, but the reality is, had we not done the dissection, that cancer would have come back. And PCR studies where we look very carefully at those remaining lymph nodes suggest maybe another 15 to 20% of patients have that disease we never would have seen. So it's not 80%, maybe it's 50%, 60%, but clearly a large group that aren't benefiting from that additional surgery that we're recommending. On the other side of the coin, we know, and you saw those slides, that if the disease is in the lymph nodes, there's a higher chance there may be cells somewhere else in the body. And in this case, taking out the lymph nodes is like closing the barn door after the houses have left. There may be some benefit to preventing it from coming back under the arm or in the groin, but it's not really changing ultimately what's going to happen with that patient because the cancer is already destined to come back in the lungs, in the liver, someplace else, someplace my surgery isn't helping. But this is the group that we're most concerned about. These are the patients, there are cancer cells in those additional lymph nodes. It's no place else in the body, and getting it out now would improve the likelihood of curing that patient. It would get rid of those last few cells, and the cancer is not going to come back someplace else. But even this group can be split into 2 groups. The first are these patients where the cancer has come back in the nodes, but it still hasn't spread anyplace else. So I feel the node underneath the arm, we get a CAT scan, a PET scan, we don't see it anyplace else, we go back to the operating room, we remove that disease, and those patients still never have the cancer come back in their lungs or their liver. So delaying that complete node dissection didn't really affect the patient in terms of their overall survival. We've still cured them even with the delay. It's that last group, that in that interim, that time period between when I didn't do the surgery and when I felt the cancer come back, that maybe it spread from that lymph node to another part of the body, and I lost an opportunity to cure. But as you can see, we're getting down to a very small number of patients. Let's say that's 1 out of 100 patients. And it's probably not worth putting everybody through the operation in order to save that 1 and put the others at the risk of lymphedema and other complications, although if you're the 1, you may argue that point. But if it's 5, 7, that's a significant number of patients cured by the operation and would be worth continuing to do. So once again, we find ourselves in a situation where we're trying to address this with a randomized study. And this is a study I may have spoken to some of you about. This is the MSLT2 trial. This is a follow-up study where now patients with a positive sentinel node are being randomly assigned to have the complete dissection or not have the complete dissection, so that we can finally learn, if we don't do that complete dissection, what's the chance of the cancer coming back? Does it impact overall survival? How many patients are eventually going to have that operation? What are the side effects, the toxicity? All of the questions that I wish I could answer there in the office, but I have to just sort of feign ignorance because we really just don't know the answer to these questions. And so this is an important study that's accruing right now, and will hopefully provide some of the answers. But what we're really very hopeful for is this. These new therapies that are coming down the pipe that can maybe eradicate microscopic disease so that you don't need to go back to the operating room. We've already identified these patients as high risk. The sentinel node is positive. They're going to be getting, in the future, maybe some sort of systemic therapy, and maybe that can help eradicate that disease. So now I go in and I surgically remove the sentinel node, I identify the cancer, these patients get adjuvant therapy, because we know the cancer's at a high, and that really takes care of getting rid of that disease in the lymph nodes. This is where we are with breast cancer. So what many of you may or may not be aware of is this exact same controversy occurs in breast cancer. We have a positive sentinel node, should we go back and do the complete dissection? What has been different in breast cancer is that breast cancer is very susceptible to many of the chemotherapies that we use. This has been the big difference between treating melanoma and breast cancer, and in melanoma, if surgery doesn't work, we've had very little to back that up, whereas in breast cancer, leaving a few cells, radiation, chemotherapy often takes care of it. So as we're moving into this new era, we're hopeful that that may also help minimize what we have to do surgically in order to take care of melanoma. Finally, for the last portion of the talk, we're going to talk about a little bit of a more controversial area. What happens when that melanoma comes back someplace else? And is there a role for surgery in the management of stage 4 disease? When it comes back outside of that primary area or the lymph nodes, should the surgeon be involved any longer? Moving outside of melanoma, just thinking of cancer overall, typically we have never really considered surgery as a major player in the treatment of metastatic disease. There are some exceptions to that. But the general thought is this. Here's a PET scan on a patient. You can see the graphic in the liver. There's an isolated lesion. The cancer's come back. And the patient will say, well, why not go to the operating room and take it out? And obviously, this is going to be a little bit of a bigger operation. Resecting the liver is a more significant operation than taking off some skin or taking out some lymph nodes. Why not, though? Why not get it out of there? Well, the reality is, because if you see this, there's other disease that you don't see. It's still too small to be picked up on even a PET scan or a CAT scan. And these tests are not perfect. They're not going to pick up those microscopic cells that are elsewhere in the body. And we know that most of those patients are going to develop cancer in other areas, metastatic cancer in other areas. And so the role of surgery has been relatively diminished. And we tend to favor using drugs, systemic therapies that can go all over the body and will kill all of those areas. Melanoma, however, has been an exception to that. It is one of those exceptions where we have strongly considered the use of surgery in the management of metastatic disease. But you have to select those patients very well. You have to think about certain things. Is it resectable, and how much morbidity is there going to be? So to take out some lesions from the skin, some nodules, even if it's multiple, is relatively low morbidity, and it's probably worth doing. Taking out a single lung lesion can now be done thoracoscopically, meaning we don't need the big incision in order to open up the chest. We can go with a camera and take it out, and so we have a lower threshold for doing that. Whereas taking out a portion of the liver, taking out multiple lesions from the lung, this is an area where we have to start weighing those risks and benefits. And again, many patients will say, well, why not be as aggressive as possible? But if it's not going to help, the last thing I want to do to a patient is not improve their survival, but decrease their quality of life. Leave them with complications that are going to make what time's left more miserable. And so, you know, there's always that argument for being aggressive, but we do have to think about these things when we're sitting down with the patient in the office. We also want to think about how long of a time period has there been between the melanoma and when we discover that they have metastases. If you're 6 months later, then the likelihood of surgery helping is going to be much less than if you're 3 years or 5 years later. And this has a lot to do with the biology of the tumor. So again, we're in a situation where there are pros and cons to the role of surgery when you have stage 4 melanoma. But there are some advantages. It is instantaneous, meaning when you think about drugs, it takes a while to have a reaction, you know, to see a response to some of these drugs. Whereas with surgery, we can effectively take care of it quickly. The morbidity is going down with surgery as we become safer in the operating room, as the risks of general anesthesia go down. Even operations like a liver resection can be done with very low morbidity. This was never true before, but it's relatively cost efficient. We always used to think about the costs of going to the operating room and anesthesia, but now, with the costs of many of these new drugs, surgery is not as cost inefficient as a lot of people think it is. And there's been a much stronger argument in the past for surgery because, again, we had nothing else. We had very few effective systemic therapies. And there are these studies that have shown that patients who had surgery for stage 4 melanoma tend to do better than the patients who don't. Those studies, however, are flawed because they involve what's called a selection bias, meaning if I'm a surgeon and I'm sitting across from a patient trying to decide whether to do what might be a rather significant operation, I'm going to select my patients wisely. Not a lot of heart disease that might make the general anesthetic risky, not a lot of morbidity of the surgery itself. So I'm picking those patients, like I showed you on the slide before, for the patients who I think are going to benefit the most. So when you go back and compare that, you're not really comparing apples to apples, you're comparing apples to oranges. And now, this has become even more controversial because we have these new effective systemic therapies, or at least the promise of these new effective systemic therapies. So should surgery still play a role here? And here's just one example. So this is a drug that we're going to talk about a little bit later, but it's one of the BRAF inhibitors called dabrafenib. And this is just one of the slides showing its efficacy in stage 4 disease. But a side trial of this showed that it was relatively effective in patients who had brain metastases. And this has not been true for many of the systemic therapies that we've had. And this is a drug that shows some promise. And the reason I bring this up is because when a patient presented with a single brain lesion as part of their metastatic disease, we considered the use of surgery or radiosurgery to treat that. And part of the argument was because none of the drugs we have really affect brain metastases quite well. But now, if we move into an era where that changes, it's going to shift the policy. And one of the discussions that's going forward is, do we really need to treat that brain lesion in patients who are going to be treated with this drug? So already we're starting to see a little bit of an effect of these systemic therapies on our decision making in terms of surgery in these settings. So the question then becomes, how does this new shifting landscape that we're living in, how do these new systemic agents in melanoma impact our role as surgeons? Well, should surgery still play a role? And it still should play a role for many patients because there are some things we need to consider. The media has made it very exciting, new drugs, and it is exciting. And I've been involved in a lot of that research, so I'm excited too. But we still have to think about several drawbacks to these drugs. Some of them have dramatic responses. You can see tumor shrinking. But unfortunately, patients develop resistance to that, and the tumor rapidly comes back. And so this has impact on us as the surgeon in terms of timing. When should we do that surgery? Should we wait till it gets to as small as possible? Do we want to do surgery first or later? These are the things we need to think about. And even though we talk about how great it is that there's this response rate of 15%, 20%, that's still only 15%, 20%. That might take a while to see that response. Should we wait, or should we think about surgery beforehand? And surgery does have some advantages. So we still need to think about surgery in patients with stage 4 disease. However, there are patients who we just can't physically resect. The disease is beyond what we can achieve with reasonable morbidity. It's too bulky in the lymph nodes. It's involving neurovascular structures that if I had to take, I would have to take the entire extremity. I can't, for instance, take out the lymph nodes if they're involving the blood vessels, because if I take the blood vessels, the patient will lose the arm or the leg. So these drugs may now open up a possibility of taking patients that before I had to say, listen, I'm sorry, but there's nothing that I can do in this situation, and maybe converting them to a situation where after the response, I can now go back in and operate. And this is what we call neoadjuvant therapy, where the systemic therapy comes back before the surgery, and it allows, in many cases, the surgery to become feasible. And here's an example, and this is, again, a BRAF inhibitor, and many of you are probably familiar with this, and Dr. Lau is going to talk about this in a little bit more detail, but we see these dramatic responses, and this is a PET scan where you see the metastatic disease sort of melt away, it disappears. But unfortunately, if you look at the next one 6 months later, much of that has come back. So when is the ideal time to do my surgery in this setting? And that's sort of, those are sort of the controversies that we're sort of trying to figure out right now as we move into this new era. So when is the most appropriate timing? Should we do surgery first, get rid of everything that we can see that we can reasonably do surgically, and then give these new drugs as an adjuvant treatment? Or should we give the therapies first and consider surgery in the future, depending on how the patient responds? Because if you're not responding to some of these drugs, it seemed unlikely that my surgery was going to be a benefit in the first place. So it may help us select the patients who are really most going to benefit from surgery, and thus the side effects. It's also important to think about this biologically. So a lot of people say, well, I don't understand why, if the drug is effective in stage 4, if there are patients with metastatic disease who are living longer because of the drugs, why aren't we using it in the adjuvant setting? Why not just start using it? Why do we have to go through all of these clinical trials again and again and again? It's a very frustrating aspect for physicians and patients alike. But there's a difference between a tumor that's what we call macroscopic, that has a different sort of blood supply, that has immune cells involved in it, and what we call microscopic disease, which are cells that are very tiny, may not be surviving on their own blood supply, maybe in a state of what we call dormancy, where they're sort of just asleep, as it were. And it may be that some of these drugs are not effective at treating the asleep cells as they are at treating the awake cells. And we know this because of all the cancers. We have seen many, many drugs that have shown great efficacy in stage 4 disease that did nothing when we moved into the stage 3 trials. And this is why it's so important to do these clinical trials over again to make sure it works in a different patient population. And part of this is actually still unknown to us. And I'm going to spend just my last few minutes on the immune system, because I'm a tumor immunologist, and part of the basic science research that I do is looking at the ways that the immune system interacts with melanoma and therapies to sort of augment that. And what you're looking at here is a dendritic cell. You can see the tumor cell. This is a tumor cell right here. And the tumor cell has proteins, antigens, that are unique to it, that make it look different than the rest of the cells in your body. Just like a virus or a bacteria looks different to your immune system than the rest of your cells. And that's how we fight infections. And those same sort of proteins can be present on a tumor cell. And this cell here, the dendritic cell, is the cell that's responsible for identifying that, for taking these proteins, these antigens, and saying, these don't belong here. And any cell that has these proteins is not a cell that we want. All right? And again, that's exactly what we do when we fight viruses. And it tells the T cell that you should look for any cell with that protein and eradicate it. And that T cell becomes activated, and this is just a different figure, it doesn't actually turn orange, but that T cell goes out, and it says, okay, I'm going to look for any cell that has these proteins on it, and I'm going to kill it. And here's that melanoma cell again, and it's going to kill it. For many years in immunology, we thought all we had to do was this part. All we had to do was get the antigens into the dendritic cell somehow, and the body would do the rest, and melanoma would be cured. And we've focused on vaccines and taking the genes for the antigens and putting them into dendritic cells, or just giving cells, irradiating them so they won't grow and injecting them back into the patient. Anything we could to get the immune system to recognize those. And we learn, and we're humbled by the fact, the immune system is much more complex than this. And this is just step 1, because there are roadblocks along the way. Roadblocks that stop that T cell from becoming activated. Okay? And that's actually an important part of the body, because you don't want to get your T cells, for every little infection that you get, to just keep growing out of control, because otherwise those T cells would take over your body, and that's exactly what happens in mice that have no brake on that system. They get what's called T-cell lymphoma, a whole new type of cancer where the T cells go out of control. So there are natural brakes that the body has in order to stop that from happening, and we need to cut that brake. And one of the brakes is something called CTLA-4. And cutting that brake can stop that from stopping, as it were. But then we need the cancer cell to actually be killed by the T cell. So we can generate antibodies and T cells and white blood cells that recognize the cancer, but if the cancer just scoffs at them, then that's not doing anything for the patient. And it turns out that the tumor is not an innocent bystander here. It has mechanisms by which it stops the T cells from being effective. And again, just one example is PD-1. And this is a protein that's expressed that can actually bind to the T cell and kill the T cell. So the T cell comes up to the cancer cell, says, I'm going to kill you. The tumor cell says, not so fast. And it kills the T cell. And so for all we do on this side of the screen, we get nowhere on that side of the screen. And some of these drugs that we're seeing benefit in melanoma are doing exactly that. They're not generating an immune response, they're letting that immune response go forward. And here's, for example, anti-CTLA-4. And this was the randomized study where the patients who got anti-CTLA-4, either with or without a vaccine, did better than the patients who got a placebo, a non-functioning drug. And that's very impressive. I'm very excited about this. Why? Because I was one of the first to actually show the effects of anti-CTLA-4 on human cells. And this is what I did when I was in training. And so to see the result of that now actually being used to actually treat patients is very, very exciting. But there are still just as many questions raised by this as there are answers. Here's just another example of, I talked about that protein that cancer uses to kill the T cell, anti-PD-1. Well, if we can block that protein with an antibody, can that be effective in helping those T cells eradicate those melanoma cells? And here is a study, very early study, showing that it can potentially be beneficial. And again, we're going to talk a little bit more data in that regard. But what does this mean? Well, to use the immune system in order to kill cancer cells is a battle, and it's a complex one. So, the first step is actually generating these antibodies, these blood cells that can recognize the cancer. And again, that's where most of our research has been focused on. And we have many ways for doing that. We can generate whole armies. We can give you whole armies of T cells that recognize the cancer. The problem is the body naturally wants to temper that, okay? And it has a whole series of mechanisms to slow down your immune response. We won't go into the details of it, but it's got its own army too, because it doesn't want your immune response to get out of control. And here is where anti-CTLA-4 comes in. It's helping to diminish that effect. But even if we eradicate that, and our army moves forward, you've still got the tumor, which is an impenetrable cancer. It's got its own defenses. It's got a fortress. And now, that's where anti-PD-1 comes in, to try to help that army overtake that castle, all right? But what it means is, we've got to use multiple drugs and several steps in order to move that immune system along to the point where it can actually stop your cancer from coming back. And there are a lot of questions that go along with this. So the beginning of that slide where we generate the army, we need an immune response to be developed. Now we do that with vaccine, but it's also happening when the tumor's in place. So for that patient with stage 4 disease, who has a tumor in place and is generating an immune response, these drugs may do a great job increasing that immune response. But if I've operated and I've taken that metastatic focus out and that immune response is not ongoing, I might have shot ourselves in the foot in terms of moving that immune response forward. And we have to study this, and this is one of the things we're looking at. How will we use these drugs? In combination, in series? Do we give one, and then we give the next, and then we give the next? And these are where some of these studies are going. And this last one is a very important one. One thing that we're missing is how do we figure out which patients are going to respond and which patients aren't? And again, just like with surgery, we don't want to offer drugs that have side effects and toxicity if the patient's very unlikely to benefit. And we're doing quite a bit at Michigan trying to identify factors that may predict which patients are going to respond to immunologic therapies such as this. So there's a lot of ongoing questions in this regard. So to conclude, it's a very exciting time in melanoma. There's no doubt about that. We're finally, after years of sort of seeing very little progress, seeing these sort of rapid extensions. And this shifting landscape not just impacts the medical oncology side of things, but also the surgical side of things in terms of what we should do with surgery to not only effectively treat patients, but minimize the morbidity of that treatment. But there are a lot of new questions that need to be answered through research. We see the increasing importance of staging patients through sentinel node biopsy, the role that surgery may play in the management of stage 4 disease, and melanoma is becoming much more multidisciplinary. You have to target patients specifically, go by patient when making these decisions, and it has to have close coordination between a surgeon, a medical oncologist, a radiation oncologist, and a whole team of doctors to make sure that we're making the right decisions for every patient. Thank you very much for your attention.